Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Congenital heart disease, any heart abnormality you're born with, is the most common birth defect across the world. These heart problems occur as a baby's heart is developing during pregnancy. About 1 in every 100 live births in West Virginia have congenital heart disease. That's the bad news. The good news is some truly amazing treatments for these heart conditions, many of them minimally invasive and only available at a small group of hospitals, are available right here in our front yard at the WVU Medicine Children's Heart Center. So today, we're talking about some of those amazing pediatric heart procedures such as the Harmony valve, Preemie PDA Closure, and stents for tiny vessels with Dr. Alex Verhoeven, Director of the Pediatric Cath Lab at WVU Medicine Children's. Welcome, Dr. Verhoeven, to Live Healthy West Virginia.
Thank you for having me. I'm proud to be here to help represent the Pediatric Heart Center and all the things that we do to help these kids that are, sick and need our assistance.
Well, it's good to have you here. So I know I talked a little bit about congenital heart disease, but let's hear it from an expert here first. What exactly is congenital heart disease and how do you usually treat it?
Yeah, so it is a wide spectrum of things that we deal with. And, the short answer is it's any defect or abnormality in the heart that we see, from birth onwards. Many don't get diagnosed directly at birth. Oftentimes they're shortly after, and some of these things even years later. But the degree to which they need assistance sort of dictates when we do stuff with them. Some of the stuff we simply watch and see how they develop. Some things sort of heal themselves, for lack of a better description. And some of the things need significant interventions and multiple surgeries or multiple cath interventions, those sorts of things. And so it runs a huge spectrum. And one of the things that's truly interesting about it to people like me who work in this field is none of the kids are the same. So, we have these categories that we sort of put things into, but not every kid born with a particular thing is exactly the same. And so we oftentimes have to sort of modify or sort of customize some of the things that we do in order to address it for each individual patient.
So it's quite a range, huh?
Yeah, it's very extensive.
So what are the most common types of congenital heart disease that you treat?
So me being in the cath lab sort of automatically puts it in a subsection of things, and particularly things that need work done. The two most common things we do are ASDs, which is a small hole between the top two chambers of the heart. And so we put a device inside that area that allows it to be closed. And then eventually your tissue grows over it and seals it up. Sort of becomes the way I describe it typically is you ever had like a pencil lead stuck in your hand and it gets sort of that little calcified area around it. Yeah, so it sort of does a similar thing in your heart. Your own tissue grows around it, sort of seals up this device, isolates it off, but also in that process seals the hole off as well. PDAs are the next most common thing. It's a structure that's supposed to be there. We need it when we're developing in the womb, but it's supposed to close shortly after birth. And in some kids that persists, or particularly in our premature baby population, that persists in a very problematic way for some of them. And so rather than sometimes waiting for it to close in those patients where it's sort of injuring the lungs along the way as well, in a patient population that already has trouble with lungs, being born premature, we'll go in early and sort of close those sorts of things. So those are probably the two most common things we do, but we do a wide range of things, and frankly, most of what a modern pediatric cath lab does nowadays is available to us here at WVU. So we do everything from the basics like an ASD or a PDA to we're on the front end of using what we call pulmonary flow restrictors and stuff to really help get some of our teeny tiny babies to a point where surgery is even an option for them when historically that wouldn't have been the case.
Wow. Well, we're going to talk about all that. So let's start first with a condition called, correct me if I'm saying this wrong, tetralogy of Fallot.
That is correct.
And you recently treated the first patient with this heart defect with the Harmony transcatheter pulmonary valve at WVU Medicine Children's. And can you tell me a little bit about the patient? It's Zach Haberline?
Correct.
Okay. Zach, tell us about Zach's case, because this was a big deal, wasn't it?
Yeah. So I'll give a little bit of background on what tetralogy is, just for the people who don't understand it first. So it's when we say tetralogy, the tetra means 4. So it's a component of 4 different things that are wrong in the heart. And typically that gets corrected in babies somewhere in the first 6 months of life, give or take. And one of the components of fixing that is we actually remove the pulmonary valve, or the valve leaving the heart going out into the lungs. That seems like a drastic and dramatic thing, but it's actually something historically we actually thought we didn't really need at all. Over time, we've learned that, over the past couple of decades, we've sort of learned that if you leave that alone and leave the valve not there for a long period of time, eventually we have issues that stem from that. And so we have come up with a set of therapies and things like that to help replace that valve. Historically, that's been a surgical valve replacement. They cut you open, put you on bypass, place an artificial valve of some sort in there. There's a variety of those out there. And then you've had a surgical valve replacement. What we have moved more towards doing in probably the last decade or so are what we call transcatheter pulmonary valves, or valves that we put in minimally invasively in the cath lab. The hole is about this big, about the width of like a thick computer cable, like for a power cable or a monitor or something like that. And that allows us to go in through the vein in the leg, go up through the heart, and put the valve in that way.
What a big difference that is.
Oh, it's a dramatic difference. You don't get your chest cracked open.
Yeah.
You don't get on bypass. You don't have the pain and soreness and recovery that comes with having your chest cracked open. So most of our patients come in, they have this done, and there's a couple of different types of these valves that we use, and I can sort of go over those real quick. But most of those patients go home the next day.
Wow,
and
the next day.
The next morning, probably. And most of them feel fine the evening of. Most of that's just sort of worry on our part, frankly, and wanting to make sure that this big transition they've had where they had no valve and now they have a valve, they make that transition and do so appropriately. And so, they usually feel pretty good the next day. Mm-hmm. Most of them can get back to doing their normal things pretty quickly in the next couple of days or so. I restrict them from swimming and stuff for a couple of days, but that's really the extent of it.
Wow.
Versus surgery, weeks of recovery, it's painful. Bypass in and of itself has its own risk profile to it. I mean, we're stopping your heart. We're letting a machine take over both your lung and your heart's body or processes. So being able to avoid all those things, in my mind, is a pretty meaningful thing. And I joke with our surgeon that I'm never going to lose that argument with him if I have to sit there and compare with patients.
Well, and I think that's what a patient would want if you choose, right?
Yeah.
That's what I would want.
So about a decade ago, a company called Medtronic, is a large medical devices manufacturer, bought the rights to what they ultimately became the Melody valve, which was a valve that we could put in that position that you put on a balloon and sort of expand and sort of seats it in there.
Okay.
That valve had a lot of restrictions to it, in the sense that most patients weren't a good candidate for it.
Oh.
So only about 25% of the patients who had a repair of their tetralogy of flow had the right anatomy for us to be able to do that. And so immediately the sort of fight was on, or whatever you want to call it, to find something that could meet the rest of these 75% of patients' needs.
Sure.
And that process took a long time. Took over a decade. What we call the RVOT, or that area leaving the heart going out to the lungs, is a relatively violent area in the sense that it's right up against the back of the sternum. And so it gets hit often. There's a lot of movement in that area as the heart's moving and the lungs are moving. And so this device has to be really resilient, but at the same time has to be pretty moldable to fit a wide variety of shapes and patients. And particularly after a tetralogy repair, that area can be, frankly, as unique as a fingerprint in how it looks. Wow. Every patient's looks completely different when we look at it on CT scans and MRIs and all that sort of stuff. And so finding a one-size-fits-all sort of device is a pretty complicated and difficult process. Ultimately, about a year and a half-ish ago, maybe even closer to 2 at this point,
Okay.
Medtronic got their FDA approval for the follow-up to the Melody valve, which is the Harmony valve, which is what Zach got.
I like the musical names.
Yeah. I sort of worry a little bit about where they're going to go next with it, because like refrain and stuff seems to carry a bad connotation. But the options there sort of allowed us to expand this to other patients. So I had actually taken Zach to the cath lab previously to potentially put in a Melody valve. He was a patient who we said, you're sort of on the borderline. We may be able to sort of sneak our way and pull this off. We may not. We'll sort of see. And when we got in there and did the sort of testing that we do to make sure he's a good candidate for it, we realized Zach's not a good candidate for this valve. But we knew the Harmony valve was sort of coming down the line.
And how old was he at this time? 15?
Yeah.
Okay.
And so we said, you know what? Rather than force you down a surgical pathway, he's a healthy kid. He's playing sports. He's doing the things he needs to do. There's no urgency to this, right? So we said, why don't you give us 6 months or so? Because that's about what we know the process is going to take to sort of get this all lined up and get ourselves sort of familiar with the device, get ourselves on that pathway of, getting it available to us.
Yeah.
Because the initial rollout was all for the centers who were involved in their trials of it.
Okay.
And so the first year or so was really a pretty narrow set of hospitals that was doing it. And then that sort of expanded outwards. And we were one of the first hospitals outside of that trial system to sort of start getting involved.
That's great.
In it. And that's because they recognize that places like WVU, who serve a relatively fixed population who don't have, all these options all around them. We need to be able to access these things for patients because some of our patients don't have those choices. And so they work with us to help sort of make those available for them. And so Zach was our first patient that we put this in. And it comes in, we sort of talk with them, tell them what it's going to be, all that sort of stuff. Zach's was actually a pretty, we call these having landing zones. Zach's was a pretty narrow landing zone, to the point where the person I had sort of training me and teaching me how to do it was like, I don't know if this would be the first one I do. Just because it was a small window and you had to sort of place it specifically and all that sort of stuff. But we did the things we needed to do, learned how to do it, all that sort of things. And it went about as good as it could have gone. I was very happy with how all that turned out for him.
And how's Zach doing now?
I saw him a month or so ago. It's like his 6-month follow-up from things. And he's doing great. He feels good. He feels better. He did what a lot of our pulmonary valve patients did, where he felt like he was playing sports and he felt like he was doing well and didn't really have any concerns. And now that he's actually doing well, he realizes that, I was just compensating for how I was feeling back then. He goes, now I'm really good. Because I was good before, but now that I've taken away this thing that was sort of making me inefficient, I'm doing much better than I thought I was doing. So I think that's what we look for. I expect that patients to start to see that transition about 2 to 3 weeks out. But that transition will sort of continue, and they'll continue to see changes over the next 6 months or so.
How exciting for him.
Yeah, I'm quite happy for him.
That's excellent. That's excellent. So what would you say are the main benefits of the Harmony valve?
So I'd say the first thing is that, like any other transcatheter pulmonary valves, the Melody valve, all that sort of stuff, we're doing this minimally invasively, right? Like we talked about it, through the leg, not on bypass, small-ish hole. All I got to do is throw one stitch at the end of it, closes up the vein.
It's amazing.
And then they go home the next day and they do well and they recover. To me, that's far and away it's an easy win. The component that the Harmony valve gives us is this additional set of patients. So, like I said, the Melody valve sort of restricted us to the best 25% or whatever. And the Harmony valve really stretches that out to not quite 100%, but as we learn more and more about this valve and the limits that we can sort of take it to, which is a natural progression for any new device, we're really looking at it covering the vast majority of those patients that sort of sit there. There's probably another 10% or so that just it's gotten so big that even this massive valve, it's probably not big enough.
Wow.
So they still need surgical repairs, but this is allowing us to do and help a lot more patients in this way than we previously have been able to.
And did you work with Medtronics in designing or customizing Zach's Harmony valve?
So we don't customize the valve per se.
Okay.
So they come in two sizes essentially. That's ultimately after all these, this decade plus of sort of development and all that sort of stuff and figuring out how to make as few lines as possible fit within the most patients possible in this very unique space. That they've come up with these two. But what we do is we send CT scans, MRI scans, all that sort of stuff to Medtronic, and then in collaboration with them, we sort of virtually implant this valve into the CT scans. We animate it and sort of figure out landing zones and positions and all that sort of stuff.
Yeah.
And so we get a really good idea through our collaboration with them of what it's all going to look like before we even get in there. And that's really sort of the benefit. So historically, we'd go in, we'd take our pictures, we do all these things, we take measurements and sort of put the older valves in. With the Harmony valve, I'm going in and I pretty much know how it's going to sit, where it's going to sit, what it's going to look like, all that sort of stuff based on all this modeling and everything that we do with the company. And like I said, Zach's had a very narrow landing zone, pretty small one. It was less than 1 millimeter. We had to sort of get it to land within.
But you found it.
Well, we got it and looks great. Some of our patients, that can be much larger. And, it's a much easier day.
Yeah.
But it's a little less nerve-wracking at times, too, because you don't have to worry about it doing anything else, going somewhere else, any of that sort of stuff. But the goal is to take what the patient has given us and all their unique anatomy and all that sort of stuff and find a way to make this thing work for them and find out where and how and all that. And so the company helps us do that by analyzing all of the data that we have and putting that all together and finding a way that works for each individual patient. We get about a 10-page report for each patient.
And it's my understanding there's only a small group of hospitals that have access to the Harmony valve, and WVU Medicine Children's is the only hospital in the state that has this, correct?
Correct. So like I said earlier, it was rolled out to initially just the first few trial centers, and they wanted to sort of make sure that once it was a true sort of product in the market sort of thing, that things went well. And then they sort of slowly expanded that out to other centers that were not initial implanters in the trial. And one of those was us. And so there are not a lot of pediatric cath labs in the country, period. And there are certain states which have 0. So we're actually fortunate in West Virginia to even have 1. But, even of that small subset of centers that have a pediatric cath lab and function in this way, I think about half of them at this point probably have access to the valve. So you're looking at probably 30, maybe 40 programs in the entire country.
So we're very lucky here.
And I think
we really are.
Yeah, I think we've been very open and very forward to bring new technology to us, knowing that our patients and all that need stuff here, and we don't want them to have to travel long distances and everything to get, frankly, truly modern, groundbreaking care for them.
So the Harmony valve that's just an amazing, that's like a mind-blowing treatment to me. But so let's talk about some of these other treatments that we offer. Pulmonary flow restrictors. We talked about these earlier, but what are they? And why are they a big deal when it comes to treating congenital heart disease?
So this is a thing that in our field, and when I say our field, I don't just mean the cath lab, I mean pediatric cardiology overall. We've sort of been looking for an option or an answer for a while. So we have a set of defects which can have pretty significant impacts sort of very early on in life, in the sense that like they need their repair in the first oftentimes couple of days of life, first month, that sort of stuff. But there's also some things which in some patients they can last for a while and sort of grow and get bigger. But in a small subset of those patients, for a variety of reasons, they may need stuff done sooner, or they may not tolerate their lesion as well, that sort of thing. And so historically, sometimes people have done what we call a pulmonary artery band, where surgically they go in and they take a small piece of Gore-Tex typically and sort of wrap almost like a rubber band around the artery leading out to the lungs in order to sort of narrow that area and decrease the amount of flow to it.
Okay.
And that's to sort of help compensate for some of these defects. There's always been a limit to that, though. Once you break about 2.5 kilograms, so it's about 6 pounds, give or take, the risk of heart surgery in an infant goes up exponentially.
Really? So the older, the bigger they get, it's riskier?
Less risky.
Okay, less risky. Sorry. Okay, sorry.
No, you're good. So as you go lower and lower and lower away from that, it becomes more and more and more risky. And so what happens is we get, unfortunately, we have a lot of babies born premature nowadays for a variety of reasons. And some of those kids were coming out with defects that need urgent, immediate repair, and they're like 1 kilogram, 1.5 kilograms. So they're like 2 to 3 pounds. So they're not even halfway towards where we want them to be size-wise. And so, I mean, even when you're at that 2.5 kilogram range, you got to understand, our heart surgeons are working on a heart that's this big.
Oh my God.
And so, when you're like, why don't you just do it on a smaller kid? Well, that matters. And then they're also being put on a bypass machine, which frankly, the bypass machine in some of these kids has more blood volume circulating around it than their bodies do. And so trying to avoid all these things is a meaningful thing. And at the same time, putting them on bypass and doing all those things carries a lot of risk with it. And so we wanted a way to allow those kids to tolerate their lesion in a meaningful way so they can grow and feed and do all the things they need to do. And if they need other stuff done, because oftentimes heart defects come in a constellation with other defects, stomach problems, that sort of thing.
Sure.
So they can get other stuff done in the meantime as well that allows them to sort of become a more optimal surgical candidate. And so what we as a field have discovered is they're called microvascular plugs. They were originally designed to be used in the interventional radiology side of things for neurologic stuff, strokes, that sort of thing, aneurysms in the brain. And we learned that we could take one of these, it looks sort of like a football, and we could poke a hole through the center of it and implant these in the tiny little arteries out in the lungs of these little kids. And we can use that to limit the amount of blood flow going out to their lungs. And these things come out very easily. They don't require a lot of sort of surgical work to remove them. They tend to just sort of slide right out. And so we don't worry about injuring the arteries in these kids. But at the same time, it allows them to not have some of the issues that go along with their lesions. And so we've had a number of kids now that we've done this in, both sort of planned in the sense that we knew they were coming out, they were going to be very small, we knew that they'd need something done early on. And we also had a patient who we did it emergently on. So she, first thing in the morning, was incredibly sick. And we said, this is kind of her only option.
Yeah.
And so we rushed her downstairs, and through the skill of our anesthesia team, managed to sort of get her in a reasonable, stabilized spot that we could do this emergent procedure on her. And she did fine. She's now a healthy kid sitting at home doing well.
Oh, wow.
Like almost a year later, actually, at this point, I think.
Wow.
So this has been it's been an interesting learning experience for us. I went and talked to the ACC, which is the American College of Cardiology.
Yeah.
I went and had a talk sort of talking about how we do these things and our approach with it and how we use it to grow some of these teeny tiny babies to this point, to sort of help teach other people how to do this stuff as well. And it's been a really rewarding thing for us to be sort of on the forefront of how this functions and all that.
So these flow restrictors are really groundbreaking in helping teeny tiny babies.
Mm-hmm.
Wow. So what kind of pioneering work is the team at WVU Medicine Children's Heart Center? What kind of pioneering work with flow restrictors in tiny babies are you guys doing?
Yeah, so
I mean, I know you've already told me some of it. Not that we're not impressed, but I know there's more.
Yeah, so I mean, the real difference between this and what other people have used these devices, it's all very new within the last year sort of stuff. People are using it for different things. What we've been using it for, or have had the benefits of using it for, and are sort of a little bit different than how some other people have, is we've used it in some patients who historically people would have sort of just crossed their fingers and hoped that they could sort of inch them along until they got to a better spot. And we've done it to allow them to grow and to do so easily. Whereas a lot of other people have used it in very specific lesions with a combination sort of approach with some other things. That is also very good, very interesting work, but is also very specific for very specific lesions. And we've sort of demonstrated that you can take this approach and use it in a variety of different circumstances for kids who otherwise would have probably struggled a lot. And now it sort of allows us to do this and allow them to have an easier course, and frankly, have a course, period, for some of these kids, and get them to a point where we can then hand them over to our surgeons who do a great job sort of doing their side of things as well.
All right, let's talk about another amazing treatment. Well, first we have to talk about a common pediatric heart defect. I hope I'm saying this right. Patent ductus arteriosus. Am I close?
A patent.
Patent.
Yeah.
Patent. Okay, patent.
There's probably a patent on it, but
okay. You say it then.
But it's a patent ductus arteriosus. Most people, if you say a PDA, at least in the medical world, they'll know you're not talking about kissing people and stuff.
Yeah. Yes.
But so that has been one of the classic defects that we have treated in the cath lab historically.
Okay.
So one of these things, like
What is it?
Sorry, yeah, I guess that would make sense. So it's a normal structure, supposed to be there. We use it to bypass our lungs when we're in the womb because we're not breathing in the womb. So why waste all that energy and all blood flow and all that sort of stuff pumping into lungs that frankly are doing nothing? And so we have a couple of different ways to bypass that. This PDA is one of those ways.
Okay.
It is supposed to close shortly after birth.
All right.
And in some patients, it never does. Some patients, it almost gets there, but just sort of doesn't quite get there. And then in other patients, we sort of have to a little bit more aggressively go after it. In older patients, so I occasionally get like a 4 or a 5-year-old who comes to us who has a small one. We sort of talk about the pluses and minuses of closing it and whether we need to and all that sort of stuff. Those are sort of the classic patients we saw with this and who were the first ones sort of addressed by it in the cath lab. And this was probably 20 years ago.
Yeah.
There's been a lot of change in the types of devices and the safety of those things. Some of the initial cath devices had like claws on the end of them to sort of hold on to things. They're very scary looking.
Oh.
Nowadays, that is not the case.
Okay.
We've sort of learned a lot about sort of what we can and cannot get away with. And the safety profile fits that as well.
Okay.
But that's sort of the classic thing. And then we sort of expanded that, and that people kept pushing the envelope lower and lower. And we hit a point where we just didn't have devices that adequately fit patients below a certain size. And that matters to us because we work in pediatrics, right? And so we have kids of all sizes. And the particular population we struggled with that is our premature infants. So kids born really before like 28 weeks or so, they struggle with this a lot. And a lot of them need to have this more aggressively treated than other patients. Okay. So the process that occurs in the body that allows for this thing to close normally, because everything is so small in those patients, just can't happen. It sort of relies on distances between things, and those distances are just so small that what we call a diffusion gradients and stuff across it they can't happen. It's thin enough that stuff just sort of permeates through the whole thing.
Wow.
And so these kids are born premature. They already have lung issues as a consequence of being born premature. And then you have this structure in the blood vessels of their body, which is just allowing tons of blood flow to flood their lungs. So you're sort of taking sick lungs and then beating them. And that obviously isn't how that should go.
Right.
And unfortunately, historically, our options were to give them medications sometimes. And as weird as it sounds, simple things like ibuprofen and Tylenol have been found to sort of sometimes help close that down.
No kidding.
But it's not as effective in the smaller group because you're trying to modify a process that can't really happen anyways. So you can modify it all you want. It's not really doing much.
Right.
And so we were really sort of restricted in that group. And so, again, like I said, there was a lot of finger crossing, hoping they did okay until they got big enough that we could do something about it. We have since gotten a couple of other devices, the most prominent of those being what we call the Piccolo device, more musical themes.
More music.
This is a totally different company. I have no idea why. Just is what it is. I can tell people I'm a music therapist, I guess. But this device, true to its name, is tiny.
Okay.
And it allows us to close these PDAs in really little babies. So our current...
How little? Like, what are we talking
my
about?
My current low score, I think, is 600 grams.
Okay, so what is that?
So that's about a pound.
In pound. Oh, my gosh.
Maybe a little more, 1.2, something like that.
That's teeny tiny.
Just doing quick math in my head.
Yeah.
Yeah, itty bitty. The kid was probably about that big.
Oh, man.
So we go in, we put this device in there and sort of then take them back to the NICU and allow the NICU to sort of recover them.
Sure.
How they would do for any other premature baby. And the hope is that this allows them to take less injury to their lungs and things like that, and ultimately allow them to get extubated or take their breathing tube out sooner, so that their lungs have time to heal, and you maximize the capabilities of the limited amount of lungs that oftentimes these premature babies are born with. And we started doing that probably about 2 years ago, give or take, and have done a number of them since. And it's not a silver bullet. These kids are born premature, and so a lot of them have other issues as well. But we've seen kids who really, really struggled. You close their PDA, and they were here for a couple of months, and they went home like a week later.
Wow.
There's the other side of things where we've done it, and I still think it's beneficial because you are taking away this extra stressor on the lungs.
Right.
But they have a number of other things going on with them that they require some time. But I think it's always beneficial if you have a problem to get rid of it.
Yeah.
Obviously, that's what my job is, so I'm sort of inclined to go that way.
Yeah.
But the other part of my job is to understand who I think it benefits most. And I think this population of patients, I think this is a really meaningful option for them. It allows them to sort of progress.
Amazing stuff on tiny, tiny, tiny little babies. That's just amazing. So let's talk a little bit about the expertise at WVU Medicine Children's Heart Center and the fact that the Heart Center is focusing on care close to home. Like these procedures that we've been talking about, you're going to have to come to Morgantown to have that done. But maybe you can have your follow-up appointments closer to your home because we're expanding around the state. Can you talk a little bit about that?
Yeah, absolutely. So I would say our heart center in the last couple of years has really sort of tried to grow and expand. Historically, everyone sort of knew Dr. Gus and sort of what he had done here. And that's sort of the starting point that we worked with. And then we said, we want to take the historical legacy that we have here, build upon that, create essentially what we hope to call a world-class center, by bringing in all the right people, by having the right people there, and then allowing us to provide everything you could get anywhere else to the patients of West Virginia, and frankly, nowadays, even the surrounding areas.
The region, yeah.
And we have patients who are coming to us from Northern Virginia, out in Maryland, that sort of stuff. And I think that speaks to the fact that we are proving ourselves to have done that. I think we've taken that legacy and just built further upon it.
Excellent.
We have outreach clinics all over the state at this point. Most days, somebody is somewhere out there seeing patients closer to home. And that all, like I said, that all brings it back to here, right? So, I can't have a cath lab all over the state. I don't know the official numbers because fortunately, when I asked for things when we built the new children's hospital, they were very sort of accommodating and sort of allowed us to have the things we want. Mm-hmm. At some point in time, someone told me that the pediatric cath lab is the single most expensive room in the entire WVU health system.
Wow. That makes sense, though.
So
it does.
Yeah. Mm-hmm. You can't have that everywhere, though, right?
No, you can't. No.
And so, unfortunately, it means you do have to come here for some of those sorts of things that we do. It's a very technology-intensive process.
But you can do the follow-ups.
Correct.
In just about most parts of the state.
Yeah. So I typically like to see my patients back shortly afterwards, simply because I like to know how they're doing.
Sure.
But we can also set things up to see some of my colleagues and all that sort of stuff in various parts of the state. And definitely long-term care can be handled closer to home, and which is really our ultimate goal, right?
Sure.
We don't want people to have to drive 4 hours, 5 hours, whatever it is.
For a follow-up appointment.
Just to come say hi and get an echo and say, hey, everything still looks great. Like, I'm glad that everything still looks great.
Yeah.
But we can do that closer to home for you. And that's sort of our next step in what we're really sort of doing. And frankly, rapidly growing to do that. We've added a ton of clinics in the last probably 6 months to a year.
Excellent.
To allow us to do that.
There's a need. So before we go, I always like to ask, okay, what is the most important thing you want our viewers or listeners to know about pediatric heart surgery? Yeah,
so as we've said over and over again, this is a very complicated, very difficult field. And there's a reason people who don't practice this are often afraid of it. But at the same time, we have done, I think, a great job of making this a center that allows us to treat pretty much everything, but does so in a frankly smaller and more intimate environment. So, there are giant heart programs in the country. Those exist. And they do numbers which are just frankly unattainable for a smaller center like us. But the benefit you get at coming to a place like WVU is we have people who have trained all over the place, most of us in many of these big centers. Mm-hmm. So we have gained the expertise at those places, but we bring it back here and we do so in a closer, tighter knit environment. The surgeon that you meet is the surgeon who's going to do your procedure. The interventionist you meet is the interventionist who's going to do your procedure. All of us know each other very well. I don't have to go look at a call list to find who's on for the weekend for anesthesia or for surgery. I pick up my phone and I call them, and they're all friends, and we all sort of know each. And that closeness of the group taking care of you and your child matters, because that's time, that's collaboration, that's people willing to talk about things, and frankly, that's comfort. In a big center, a lot of times, they may do a lot of numbers, but it's divided between a lot of people. And so their numbers individually may actually be lower than some of the numbers that some of our practitioners do. And I think all that matters. Absolutely. And there's definitely a push from some of these bigger centers to isolate things to the large centers. But I think a lot is lost in that. And I think a lot of the personality and a lot of the closeness in allowing patients to stay home near their support systems in what is often a difficult time for them. I think those are all very meaningful things. And frankly, one of the reasons I and most of us are at a place like WVU is it allows us to put our money where our mouth is and prove that we can do top-notch care while also providing the non-medical things that we think are important for patients and frankly for ourselves to do a good job.
All right, great. Well, thank you so much for sharing that. Fascinating information. I don't know how you do this on such tiny, tiny little babies, but thank you for sharing. It's good to know that it's right here in our front yard. Excellent. Thank you.
My pleasure. Thank you very much.
Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information on care for kids, you can always visit WVUkids.com. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or on the all-new Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Verhoeven and everyone at WVU Medicine, thanks for joining us.